Hello, my name is Nicholas Namias, MD, MBA, FACS, FCCM, and it is my pleasure to come here today to speak to you about critical care of the liver transplant patient. Hello, I am Nicholas Namias, MD, MBA, FACS, FCCN, and I'm here to talk to you today about critical care of the liver transplant patient. I am your father. Hello, I am Nicholas Namias, MD, here to talk to you today about critical care of the liver transplant patient. Okay, so really we're here to talk about critical care of the liver transplant patient, and the thought of 1 hour on Zoom listening to me talk while watching slides is probably hurting you more than the thought of me doing that talking is hurting me. So we will try to make this as useful and as hopefully bearable as possible. It's important stuff to know, so let's get on with it. We will share the slide screen to show you the slides, and I guess we'll go into the presenter view. And there it is. We're going to talk about critical care of the liver transplant patient. Our objectives today are going to be to describe the care of the end-stage liver disease transplant candidate, to describe features of the postoperative care of the liver transplant patient that can be influenced by the intensivist, because if you've ever taken care of the patients of a liver transplant surgeon, you know you don't have control over everything, and it's a political game of compromise. And finally, to review the complications of liver transplantation of relevance to the intensivist. You will not leave here being an official liver transplanter, nor will you be an official organ procurer or selection committee, but you'll at least learn to think what your transplant surgeons are thinking, so hopefully you can work well together without inciting a war. So I guess I should tell you that I have no conflicts of interest in this area. Yeah, I can make this thing look a little better. I should be looking down on it probably. That's the problem, right? Let's go up. Meh. Okay, but I have been taking care of liver transplant patients in the surgical ICU at the University of Miami Jack Memorial Hospital since 1992 when I was a resident, assisting on these operations with Dr. Josh Miller and Dr. George Burke, having spent 8 hours holding the duodenum out of the way. I am somewhat familiar with the procedure, and having spent the night in bed with a procured organ waiting for the OR to be ready for it, I feel very intimate with the process of liver transplantation. Taking care of so many liver transplant patients, I've actually gotten myself a book. Damn mirror image with the zoom. Transplantation of the Liver, Busatil. Beautiful book. Helps you stay in the game with your liver transplanters. If you have a busy unit, I suggest you get your hands on something like that. Let's go back to the slides. That'll be this one. Okay, share and presenter view. Boom. So what are we talking about? We're talking about end-stage liver disease, which we see 40,000 times a year in the United States, end-stage liver disease. 2,000 of those cases are fulminant. Those are people who were walking around not even knowing they had liver disease, and all of a sudden they have liver failure and encephalopathy within a few weeks. So they're just minding their own business and struck down with end-stage liver disease. The definitions, you're going to hear your transplanters bring these patients into your unit with a variety of definitions. This one's a fulminant, this one's an acute on chronic. You know, for critical care, doesn't really matter that much to you, but it is nice to know that the fulminants are people who are walking around well, so they physiologically ought to have good reserve. They aren't debilitated, they aren't malnourished, and they just acutely became ill and had their livers go bad and need a transplant, or they're likely going to die. Then you have the acute on chronics, people who've had some chronic liver disease. Maybe they've been jaundice, maybe they've had malaise, but they're not really a physiologic mess, and they acutely decompensate for some reason, an infection or an injury or something. And then you have the decompensated cirrhosis, the people who have been walking around, you know, with one foot on a banana peel for years with cirrhosis, who have finally decompensated. So the last little the last little brick in the wall that was holding their house together has now given way. And those people are really going to be difficult to take care of, because obviously they've already become debilitated, weak, malnourished, and you're going to start to take them through like basically the hardest critical care thing there is in the world. So it's tricky. So what are liver transplants done for? You can see in this slide from the 2018 report of the Scientific Registry of Transplant Recipients. The most common thing is other and unknown. And I am going to have to say that since they don't include NASH, non-alcoholic steatohepatosis, in this list of things, that this has really got to be NASH, or the fatty liver that you get from the standard American diet. As obesity and diabetes increase, the NASH increases, and I think it's becoming an increasingly common reason for liver transplantation. So have another Twinkie. Alcoholic liver disease is still up there. And then we have other causes. Acute liver failure, sort of the unlucky walking around all of a sudden liver failure, less common. And other cholestatic diseases. And let's see, what do we have here? Hepatitis C on the downswing, which is really interesting, right? With the advent of the hepatitis C medications, less people are going on to liver failure and transplantation because of hepatitis C. So that's a good thing. But what we're left with is Snickers bars and Miller Lite are the main reasons for liver transplantation. So knowing that there's a lot of people that need livers, and there's way more people that need livers than there are livers to be had, they have to be allocated. And so the allocation is based on the model for end-stage liver disease, which is a mathematical calculation done on a few hundred patients many years ago, but has proven to be extremely robust. There are different scores for the adult and pediatric, but if you look at the formula for calculating the MELD score for adults, you see that it's 0.957, or roughly 1 times the log in the base of E of the serum creatinine. So creatinine plays a 0.957 role in this, plus 0.378, the log in the base of E of bilirubin concentration. Okay, so bilirubin is not quite as important as your creatinine, go figure, in a model for end-stage liver disease. And then finally, and it looks like it's cut off on this screen. I don't know which screen you're seeing, but it's 1.12 times log in the base of E of the INR. So the INR is actually the most important thing in the MELD score. And the INR reflects the synthetic function of your liver, right? Whether or not you can make the clotting factors. So in the MELD score, if you don't have the number right in front of you, or don't have your fingertips on a calculator right away, understand that the synthetic function is the most important thing. Your renal function is the next most important thing. And really your clearance function of your liver, the bilirubin, is the least important thing in the calculation. And that's where we get the MELD score from. And why is the MELD score valuable? The MELD score is a great predictor of 3-month survival. And there's the number I told you, of 1,230 adult patients they did the study in. You see that with extremely low MELD scores, your survival at 3 months is 100%. And then it goes down and down and down. And somewhere here in this, we're talking about a MELD of 30 to 35. Now we're talking about a 20 to 30% 3-month survival. And this is down here is where you become a prime candidate to get pushed way up on the list to get a liver, to become a high status patient for a liver. And after a certain point, you're really just too sick and it's not going to help you anymore. So the MELD score is the tool that the transplanters use to decide which of those patients is going to get a liver and end up in your unit. Or in some cases for you, it's going to be used to decide which patients get into your unit for evaluation for a liver transplantation. And I'm going to pause this thing again. And I hope that disoriented you enough to get your attention back to this Zoom from your email. I know how hard it is. Trust me, I can't stand it. And I will now try to go back to sharing the screen and sharing the slides. And we'll talk a little bit about the clinical features of end-stage liver disease. And the big one that gets your attention is the encephalopathy. These patients are prone to cerebral edema from a number of reasons, including their hyponatremia, including the neurotoxicity of ammonia. And one of the key things in treating encephalopathy is to get the ammonia level down. And how do we do that? There are two mainstay medications. One is lactulose. And the key to lactulose is that it's a miserable drug because you only know it's working once you've made the patient have bowel movements, and a lot of them. So when the nurse calls you for the diarrhea from the lactulose and asks if you should stop it, you say, no, we got the diarrhea, we have achieved the goal. Lactulose works by acidifying the gut, which helps convert ammonium to ammonia and drags it out of the gut and makes them poop it out. And rifaximin kills some of the bacteria as an antibiotic, kills bacteria in the gut that are producing the ammonia. And in both situations, you get that ammonia down and you can help improve the encephalopathy. Other keys to helping the brain, we have in the past, and a lot of these things are just ritual and voodoo from people you've met. They're not all in the books and in the literature, but maintaining the head of the bed up to avoid cerebral edema, maintaining the head in a midline neutral position to avoid obstructing an IJ vein. Whether or not that really helps, it can't hurt. Okay, so then there's also the hepatopulmonary syndrome. And this is a syndrome of shunting in the lung, wherein you get capillary dilatation and the patients are hypoxemic when they're standing up, they're hypoxemic on any effort, they're dyspneic. It looks like respiratory failure, but the problem is vasodilatation in the capillaries in the lung. They're better when they're supine. This is obviously a problem. And it doesn't go away until you get rid of the vasoplegia of liver failure, which we'll talk about a little later, which comes with a liver transplant. So that's one of the features. Pulmonary hypertension is very common in these patients. And although pulmonary hypertension really doesn't come from the liver failure, it's very common in these patients. We see it a lot, and it's often the main contraindication that stops them from having their operation. So all efforts at correcting pulmonary hypertension, if it's at all possible, need to be made. And finally, renal failure is very common, and it can be because of the liver failure and the hepatorenal syndrome, where the kidneys sort of sympathetically fail with the liver, but sometimes they're in renal failure from the chronic disease that they have. And in these cases, you can actually consider the patients for combined transplantation, for which there are a set of criteria, which are listed here. And they all mark fairly reasonably severe degrees of renal failure. You'll note that you have to have it for a certain duration of time. And sometimes you'll find that patients will be right on the cusp of getting their liver. Another day will make them a candidate for combined liver and kidney. And I tell you, it sure is easier to handle a liver transplant with a working kidney than one without a working kidney. But this really isn't up to you as an intensivist. Your transplant surgeons are going to decide on all of this. One of the real hallmarks of the end-stage liver disease patient is hyponatremia. These patients come in remarkably hyponatremic without symptoms. And this is not something that necessarily has to be corrected quickly. What I've sort of discovered is that these patients tend to retain sodium. So you really don't want to give them too much sodium because they will retain it, because their physiology is that their bodies feel as though they are hypovolemic. So they're trying to hold on to volume, holding on to sodium, and then they hold on to water in excess of the sodium, and they just make more ascites. So you really don't want to try to correct this hyponatremia quickly. If it is very low and you're headed for a procedure and it has to be corrected, it can be done gently with normal saline. It really shouldn't be done with hypertonic saline. And you really want to avoid rapid swings in the sodium, because you can get central pontine myelinolysis. I'd venture to guess, if you're trainees mostly in this audience, you've never seen it. And it's a shocking thing, because while there may be subtle neurologic findings of CPM when it presents, the only one I've ever definitively seen presented basically with quadriplegic flaccidity. It was awful. It was CPM where the patient was now immobile, flaccid, irreversibly. Terrible, terrible, terrible thing. So you don't want to go crazy correcting this. gentle, normal saline, only if it's getting, really low, below 120, or if you're headed for a procedure and you have to correct it, then gently, slowly correct it with normal saline. They are also vasoplegic. They are in a state of distributive shock all the time. They are vasodilated. They can't metabolize nitric oxide in their system. And we're all making nitric oxide all the time to vasodilate certain capillary beds, but our liver cleans it out. Theirs doesn't, so it just circulates. And so these people are walking around, or they're in your ICU, with a blood pressure of 90 systolic, mentating as well as they can, making urine as well as they can. They are not in need of acute massive resuscitation, because if you blast them with fluids, you are going to just make more ascites, respiratory embarrassment, intubation, and start the inexorable spiral towards death. So you really just want to deal with it. If you really need to make a blood pressure for them, there's a couple of things you can do. One is norepinephrine at low doses. Two is check for cortisol levels. These patients are frequently hypoadrenal, and they might need some replacement steroids. And three is a methylene blue infusion. Methylene blue scavenges the nitric oxide, and your blood pressure comes up. I don't know. I don't think anybody knows how long you can keep the methylene blue going for before they start turning blue. It's usually a short-term thing, but in a crisis situation, you can turn to that. Some patients will have variceal bleeding, and although a lot of centers might shy away from operating on somebody with variceal bleeding, let's go back in time before liver transplant was common. Variceal bleeding was the indication for an emergency operation to do a portal to systemic shunt. And so those patients don't need to be written off. And now, if the patient is otherwise physiologically okay, I know our transplant surgeons have operated on someone with active variceal bleeding with the Sengstock and Blakemore tube in place, because once you get them in the liver and some synthetic function, that bleeding will stop. So you decrease the portal hypertension, you get them some synthetic function, and you can pull the tube out and they can live to see another day. So variceal bleeding is not by any means an absolute contraindication to going forward with surgery. And of course, one of the main hallmarks is the coagulopathy, because they have no synthetic functions, they're not clotting. And this is one of the biggest problems, because you're sort of depending now for the patient who's pre-op or potentially pre-op. You're sort of waiting now for all of the various people who are involved in evaluating the patient before transplant and deciding whether or not they can be transplanted, to decide whether or not they can be transplanted, because your correction of coagulopathy is really only a bridge for those patients who will go on to get transplanted. You really can't correct the coagulopathy forever. You need a liver to do that. And so if the patient looks like they're a reasonable candidate, and that's where I like to differentiate the end-stage liver disease, there's a reason they call it end-stage, from your liver transplant candidate, because your liver transplant candidate is someone who you can continue to monitor, PT, INR, viscoelastic testing, TEG, targeted resuscitation, like you know from your trauma learnings, and transfuse clotting factors. And even, although it's very expensive and although it's really restricted in its use, the prothrombin complex concentrates, PCC, this is something that, you know, if you've got someone who's on the list and they're active on the list and you're hoping for a liver in a day or 2 or 3, you know what, spend the money on the PCC and control the bleeding until they can get that liver in a couple of days. But PCC is obviously no way to live ad infinitum, because your liver has failed. At some point it becomes ridiculous. So coagulopathy is a really big deal. And in the pre-op patient, you want to correct it as much as you can to where they're clinically not bleeding, including the thrombocytopenia, because you don't want to have a spontaneous stroke. So coagulopathic patient, if for some reason they get hypertensive, have a bleed into their brain. So we typically correct for platelets less than 20. We correct the coags if there's any evidence of bleeding whatsoever. And we'll go so far as giving PCC if they're actively bleeding, and we see it as a bridge to transplant in the next couple of days. Now, one of the other main ascites of end-stage liver disease is ascites. You have portal hypertension, the sinusoids are fibrosed, the fluid can't get through the liver and back out into the systemic circulation. They've got dilated capillaries in the splanchnic bed, in the portal beds, and they leak and make ascites, and they leak protein. And so these patients are malnourished from wasting protein into the ascites. They've got these big bellies full of ascites that are now pushing up on their diaphragms. They can't breathe when they're lying flat on their back. And these things are prone to SBP, spontaneous bacterial peritonitis, which is a disaster. Sometimes it's the reason they came to you. They were walking along, minding their own business with their SBP belly, with their ascites belly, and all of a sudden they're confused, or they're hypotensive, or they're in shock and nobody knows why. Frequently SBP. So those patients need empiric antibiotics, a culture, and treatment, because they are, that really could be the thing that tips them over the edge to either needing the transplant once you can clear the SBP, or dying. These patients, like I said, respiratory embarrassment from pushing up on the diaphragms, and the malnutrition that comes from the protein being lost into the ascites, and the deconditioning that comes from really the weakness, the lack of energy, the lack of exercise, the wasting of protein that comes from being one of these patients. So it is truly a disastrous way to go into a major operation. So the day comes and the transplanters call you, and they tell you either that they've brought someone in from outside for a transplant, which is great. That means it was a well patient, or your patient in the ICU now has had the miracle of getting an organ donor and is going to have a liver. And that's great. And the post-operative care, when it all goes well, is smooth sailing. I mean, we literally have some that we have toyed with having them not come to the ICU at all. I don't think we've pulled that one off yet, but we have some that come to the ICU that are really have been de-lined by anesthesia, that are extubated, that are awake, they're alert. You would think they had an appendectomy, that have done great. And when that happens, it's fantastic. Usually they're a little sicker than that, and sometimes it can go on to be obviously a real challenging issue. All right, let's talk for a minute now about the pulmonary part of all of this. Extubation and ventilator titrating. Notice I said titrating, not weaning, because you only wean if you've weakened them, and hopefully you didn't do that, and what you're doing is titrating. But the ones that come from the OR, who came in from outside, who are not debilitated, or went to the OR and had an operation, that's not a vent wean, that's a post-op extubation. And so you're just finishing the anesthesiologist's job. It might have been done late at night. They might want to just keep a little margin of safety, be with extubate at a time when there's more people around. That's fine. They come to the unit, we extubate them. Those should be simple. But now I'm going to rant on the Esteban paper from 1992 just a little bit, because a lot of you have learned that the best way to wean a ventilator to extubate is to do these spontaneous breathing trials once a day to see when they're ready. But what everyone missed from that original paper is that they spent 7.5 days on AC before anybody said, hey, maybe we can extubate this patient. Wow, Siri thought I was talking to her. No, I don't want you, Siri. Let me turn you off. Yeah, good. So the patients in that paper spent a week on AC, and personally I call AC not assist control, but always crippling. Like I said, you know, these patients in my training, and those of you, probably several of you who trained in Miami, you know, we'd rather keep these patients in the game all along, breathing. So using pressure support, having them spontaneously breathing so that they're never so debilitated they have to be weaned. So I beg of you, if you never read the original paper that led you to this daily spontaneous breathing trial to wean patients with, go back and find the 1992 paper by Esteban and find that the patients didn't start weaning until the doctor thought they were ready to wean, and that wasn't until about day 8 on average. Man, well, what do you expect by day 8? So I don't really hold much stock in that. Titrate the ventilator to their physiologic needs. Give them just what they need to maintain a minute volume and to stay in the game and participate, and then you'll hopefully get them extubated. That problem won't be cured here. And this is routine critical care across all things, not just liver transplant. Let me rant on tracheostomy now for a minute too. As far as I can tell, Every tracheostomy paper, every written, goes like this. Hypothesis: tracheostomy either shortens length of stay or lessens pneumonia or decreases mortality or decreases ventilator days. Methods: we randomized patients to this and that. Results: we showed no difference. Conclusion: tracheostomy is good because it really does what we said it did, even though we failed to prove it. No. So tracheostomy obviously is an important component for the patients who are debilitated, who really can't be extubated. But if you have someone who's not otherwise debilitated and you just couldn't get them off the ventilator in some reasonable amount of time, a week, maybe even 2 weeks, if there's some light at the end of the tunnel, there's no mandatory tracheostomy to be done. Now, some of them, it becomes clear that they're so weak that they're not going to get extubated, and go ahead and move them to a trach. But, you know, to me, if you trached them and got them off the ventilator the next day, that means you failed in extubating them. It didn't mean the trach helped them. It means you failed in extubating them. So go easy on the trachs. Just my 2 cents. ARDS happens in liver transplant patients just like it happens in everybody else. We are big proponents of proning. Now, in a liver transplant, although it is in the books about proning liver transplants, I'll tell you, I have not proned a fresh liver transplant, because if you go into all that trouble to keep their abdomen open to not put pressure on the liver, kind of find it hard to lay them on their belly and put pressure on that liver. So proning in the acutes isn't something we've really done. Now, once they've become more chronic, if someone's going into ARDS and they've had that liver for a while, yeah, we'll go ahead and prone them. It's one of our favorite maneuvers for ARDS. Inhaled nitric oxide, misspelled on the slide, but you know what I mean. Inhaled nitric oxide is a useful adjunct for bad ARDS, but we don't do it until after they've been proned. We've tried some alternate modes of mechanical ventilation. APRV has become our go-to. We've gotten away from any kind of oscillators or ultra-high frequency jets. And of course, there's ECMO, really in reserve, but it's sort of a bad combination to go through all this and ECMO, although we've done it. And if you've got a good ECMO team, it's something you can fall back on. But really, the treatment of ARDS in liver transplant patients really is not different from the treatment of ARDS in all of the other patients. People have looked at whether or not the high airway pressures transmit to the liver and cause a problem for the liver, and that data is inconclusive at best. And you know, saving the liver but having a dead patient with hypoxemia doesn't help you much. So treat the ARDS as you would in other patients. Pulmonary hypertension, we mentioned before, is a common thing in these patients. If you can't get their pulmonary artery pressure down to 35 preoperatively, the liver transplanter probably won't do the operation. But when you get them back, you know, some of the medical adjuncts for pulmonary hypertension are sildenafil and epoprostenol, but judicious fluid management and running them dry, which is something, as a trauma surgeon, is something, you know, we used to really have a problem with. But for these liver transplant patients, even going way back, I remember doing these with Dr. Burke, and in the operating room, we would be looking at the liver, and he would decide when he liked the way it looked and felt the best. And then he'd ask anesthesia, what's their CVP? And then the post-op orders were to keep the CVP at that. Some have written you want to keep the CVP at less than 5. That might be a bit extreme. But the bottom line here, pulmonary hypertension has to be controlled with a combination of diuretics and pulmonary vasodilators because it's a bad problem. Hemodynamics. We mentioned before that the liver transplant patient is vasoplegic. They're in distributive shock. And post-operatively, it takes a little time for that to recover. And I'll tell you, as a trauma surgeon, I always felt like, you know, why do the medical people have so many people on norepinephrine? And why the transplanters all want norepinephrine and vasopressin? Well, I'm starting to kind of get it now. Some people just are vasoplegic for a variety of reasons, and the transplant patients aren't metabolizing, clearing their nitric oxide. The liver transplant patients might be adrenally insufficient. And so they might need a little help with a touch of vasopressin and a touch of norepinephrine while you're getting their volume assessment completed. And maybe you're finding that they're euvolemic and still hypotensive, and I find that some of them do just need to stay on a whiff of norepi and vasopressin until they're past that hypotensive period. So how do we assess volume? Pulmonary artery catheter. Yeah, it's getting harder and harder to find a young person who knows what to do with that thing and to troubleshoot it. So, sometimes they'll come out of the OR with a pulmonary artery catheter, and if those patients are having trouble with their volume status, we'll look at the pulmonary artery occlusion pressure to try and make a decision. But normally, really, your liver transplanters don't want you driving that wedge up to 18 to 22 to make them euvolemic, because you're going to make edema in the liver and have a problem now with ischemia, with blood and oxygen reaching through that edema to the hepatocytes. So they're not looking for you to get them euvolemic by pulmonary catheter measures. Point of care ultrasound might be a little limited here. If you're good at looking at the heart, you can look at the right ventricle and see how full it is and what kind of contractility you have. It's amazing. Siri keeps turning on. And see what kind of contractility you have. Looking at the inferior vena cava is also problematic. If your transplanters use sort of the classic approach and interpose the vena cava into the native vena cava, depending on where the anastomosis is, that might affect your ability to look at the cava. And if they use the piggyback technique, now you're going to have a blind ending pouch of cava in there, unless they just did a Correll patch. So it's complicated. The anatomy can be a little screwed up. So, I think you have to work with your liver transplant surgeons to show them the IVC that you can see and ask them if they're happy with what you're seeing, and use that cooperation to decide if you can use POCUS in your patients. We have the flow track in our center. There's a lot of different devices. I have no financial interest with the flow track, and it's okay. It gives you a trend looking at the SVV, the stroke volume variability. But it's really only validated when you're in controlled mechanical ventilation in a paralyzed patient. All bets are off in other situations. And honestly, sometimes it's just a divining rod. You look at the total fluid intake, you look at the urine output, you look at the electrolytes, you assess the state of edema that they might have. You take what limited view you can with the ultrasound, see how full their veins are, and make the best guess that you can along with your transplant surgeon partner. But trust me, what they want typically are more diuretics and a lower CVP, and I can understand why, because they can't get congestion in that liver. And so sometimes, you have to suboptimize what you're doing for the kidneys and accept a little bump in the creatinine, a little damage to the renal function to do the best thing there is for the liver. And so these patients typically will stay on some diuretics and even diuretic infusions sometimes. And so that's just life, and you have to work with your surgeon partners to see what makes them happy for their organ and what makes you happy for the physiology, and compromise. Now, the choice of fluids is also tricky, because you'll find there's a lot of fetishes among the transplant surgeons. Ours particularly love albumin. What can I say? I do agree. I think the crystalloids do leak out of the vasculature faster. But, I think albumin, if depending how you want to read into it, might be a little more problematic for the kidneys. So I think that you have to, if you can get by with some intermittent small boluses of albumin or a low rate of crystalloid, that's what you have to do. There is not a magic answer for this. I'm sorry if you paid the registration fee to get the magic answer, but it's just not out there. It comes in flavors based on your transplant surgeon. So you have to find a place to agree. Years back, we found a happy agreement with Dr. Tsakis, and years later, we found a happy agreement with Dr. Viena, and you come to a common ground. One of the techniques that some of our transplanters have really liked is no maintenance IV fluids post-op, just intermittent small boluses as they begin to become oliguric, to limit the amount of crystalloid they get. And honestly, it sounded horrible to me, but really no adverse outcomes. It was okay. We have other transplanters right now who are very happy with a low 50 to 75 cc's an hour of a crystalloid, like an isolite or a D5 half, and those patients do fine. Um, I get into a little disagreement with the transplanters sometimes because they tend to use peripheral edema as a marker of overload, which, you know, you're intensivist, you're trained that that doesn't reflect your intravascular volume. But to some extent, you know, if you can take everything into account, your chest x-ray, the edema on your chest x-ray, the peripheral edema, your ultrasound, your flow track, if you have a swan, to use that, and judiciously use diuretics. And sometimes it's just empiric. You give it a diuretic, see if they respond, see what it does to the electrolytes and the renal function. And then finally, there's the management of hyponatremia, which slowly should resolve once they've gotten the liver transplant. It doesn't happen immediately, but you have to keep an eye on it, because now you're going to be on the tacrolimus possibly, and you don't want to have confusion of neurologic manifestations of tacrolimus versus neurologic manifestations of the hyponatremia. And so you judiciously will try to correct the hyponatremia with normal saline, and hopefully soon enough they get to eating and getting the salt in their diet and do better with that. What about nutrition? Here I am in front of all this yummy food, and honestly, I'm a big believer in giving them that food as quickly as possible. Early nutrition is going to be important. If they can eat, let them eat. If they can't eat, get those tube feeds started, because these patients are debilitated and need to be brought back. Early nutrition, I think we all have bought into the idea that it helps. You know, use your nutrition support people, but in the absence of those immediately, if you just got to do a back of the napkin calculation, like everything else, 25 calories per kilo per day, 1.5 to 2 grams of protein per kilo per day, and that'll get you close enough until your nutrition expert can come by and help you out. Another word about nutrition, you know, everyone seems to go through these clear liquid things. Who on this planet really wants clear liquids? And if you're going to aspirate anything, it's going to be clear liquids. So honestly, if they can take you know, 1 spoon of a pudding or an ice cream or something that stays in a viscous form that's a little harder to aspirate, and they can handle that. I've taken to moving them straight forward to a brat diet, because, you know, they just had a major operation, maybe they got a little nausea or something. Brat diet's a very gentle thing. And so I've moved them forward to a brat diet, but quickly as possible, they should go to some yummy, yummy food and stay on gastritis prophylaxis. These patients are typically going to be on steroids. I tend to keep them on gastritis prophylaxis while they're on steroids. The last thing you need is a GI bleed or perforation. And then, of course, there's the really big one in these super sick patients who are now immune suppressed: infection. This is usually the biggest cause of arguments between the transplanter and the ICU doctor. Some of them are not as hard. So surgical perioperative prophylaxis really, you know, I mean, as an intensivist, you would like the patient to get 1 dose pre-op, but, you know, I've found that for the routine patient who hasn't had a massive transfusion, who isn't at any particularly high risk, they have come around to living with 24 hours of perioperative prophylaxis, and that's fine. That's something I think we can all agree on. I think that each center is probably going to look to its own experience to choose an agent. You know, it should be something that's not massively broad. Ours have used ampicillin sulbactam. You know, you can imagine how some centers might use piperacillin tazobactam. You can imagine how some might just use cefoxitin or cefazolin and metronidazole. But the operative prophylaxis itself is really not that big of a deal or a point of argument. And it really can be flavored locally. Opportunistic infection prophylaxis is important because these patients can get CMV and they are prone to PCP. And so the usual prophylaxis for the CMV is ganciclovir, then valganciclovir. And for the PCP, it's usually trimethoprim sulfa. and in some cases based on allergies or some other things that might be dapsone or atovaquone, but they typically do stay on opportunistic infection prophylaxis. Occasionally, rarely, you'll get a call a couple days into it that the donor ended up having an infection. They cultured something with the donor. And in those situations, we tend to cover the patients for several weeks for whatever was picked up in the donor. And then comes the fever in the transplant patient. Now, this is kind of a big deal, right? Because a patient is immune suppressed with steroids or other immune suppressants. They shouldn't have a fever. That fever should be suppressed. So normally, you know, on a trauma patient, they tell me, oh, he was 38.4, and I start barking at them that that's not a fever. But in a transplant patient, you know, even as they're approaching 38, I'm a little concerned. And so those patients will get pan-cultured, get empiric antibiotics, broad spectrum, ideally based on your unit-specific antibiogram. In the absence of that, just broad spectrum empiric coverage. And the patients that are deemed high risk by whatever criteria, again, in your center, our center, they base it largely on the volume of blood transfused in the operating room, of whether or not they're high risk and whether or not they should get prophylactic antifungals. Ours typically can get them, and this again depends on the transplant ID physician on call for that particular day or week. It can be for a couple of weeks. I've seen a protocol from UCLA that has people getting prophylactic fluconazole for 6 weeks. Prophylactic antifungals are not out of the norm in liver transplant recipients, and it's something you might expect to see. I'll caution you that fluconazole inhibits the metabolism of Prograf. And so if your patient's on fluconazole, your transplant surgeon needs to know immediately because they're going to need to adjust their Prograf dosing or choose another antifungal. But you can get dangerous elevations in your Prograf level when you use fluconazole. What are some of the complications that you as the ICU doctor need to recognize for your transplant surgeons? You got to recognize bleeding. And that can be tricky sometimes because sometimes you get a patient back from the ICU, you know, the occasional rare patient will have primary non-function, or you might have a DCD donor that has delayed graft function. And then you're sort of torn between, is this drop in hematocrit and this drain output, is this expected coagulopathy from the function of this liver, or is this surgical bleeding? So as long as you're recognizing bleeding, don't ever chalk it up yourself to non-surgical bleeding. Make sure the surgeon knows, because for those of you who are surgeons, you know in your mind's eye, you can still see every stitch you threw. And if someone suggests to you that there's bleeding, that surgeon might remember the stitch that might be the cause of that bleeding. And so if there's a chance to intervene early, they should be given that chance. You need to recognize any vascular complications early on. If the liver's not working, if the ultrasound comes back and they don't see flow, your transplant surgeon needs to know right away because you can have thrombosis through small vessels or low flow vessels. And even the positioning of the liver can cause mechanical twisting or compression of the cava and even anastomoses. And your transplant surgeon needs to know right away if your liver isn't functioning the way it should be, if your bilirubins aren't coming down, there goes Siri again, she keeps starting on her own. If your bilirubins aren't coming down, or if your INR isn't coming down, they should know, and they might have some ideas of something that could be going on mechanically. And then recognition of rejection. So fever can be rejection, elevated transaminases can be rejection, elevated bilirubins can be rejection. You need to make sure you bring these to the attention of the transplant surgeon right away, and don't wait, because they might choose to up the immune suppression at that point. In the end, critical care of the liver transplant patient is really just critical care. I think what's hard to remember is that the surgeon retains ownership of the patient. That surgeon is married to that patient for the rest of their life. That patient is gone from you when the ICU stay is over. So you need to work with the liver transplant surgeon. You need to bring your skills to the table to support them in what they're doing to get that patient through this episode of their life. And you need to work with the liver transplanter, and don't be combative or argumentative. When there's two ways to see things, try to find a compromise. My liver transplanters have been good. The two changes I've seen, we butt heads for a month and then come to really a great compromise and great working relationship. And so I think you can too. There's some unique aspects, for you to be aware of, going backwards, things about the hyponatremia, things about the vasoplegia, the possible need for pressors, the use of diuretics where you might not usually use them because you're so concerned about edema in the graft, the neurologic effects of something like Prograf, the use of rifaximin and lactulose for the treatment of encephalopathy. But those are things that you pick up with taking care of the patients, talking to the hepatologist, talking to liver transplanters, getting your hands on a textbook or some review article if you're taking care of a lot of these patients. And it can end up being really rewarding because you become really a valuable and important part of this field of surgery, which is really remarkably life-saving. So with all that, I'd like to say thank you. You stuck with the Zoom. Hopefully you didn't fall asleep. Hopefully you didn't get too many emails done. See you next year at this conference. Bye-bye.